about molecular teragnostics, and I was thrilled about these huge lists of tracer you actually can use here. So probably I'm not going to tell you too much new things. When we talk about teragnostics and these new dedicated applications of therapies for patients based on targets we also can use for diagnostics, I think gallium becomes very important. And gallium has some advantages and some disadvantages, and I'd like in the next 20 minutes to talk about especially the solutions we have for those problems, and then give you also some aspects of the use of gallium and lutetium, of course, for targeted, dedicated treatment of patients. So that's the principle. You see what you treat. That's an older scan. Now with the newer technology we just have been introduced to with SPECT, those images look much better. You can use the same chelator for gallium as for lutetium, and that is of course the backbone for a lot of developments for new teragnostic approaches. You see here dotatate, dotatoc, OPS202, that's an antagonist for a serotonin receptor, all of this for neuroendocrine tumors. And of course, the big and very interesting part that now is moving a lot in nuclear medicine is the prostate. So when we talk about the potential role of gallium, then we really talk about PSMA and prostate cancer. And it is already a while ago that, we still don't have any real good randomized clinical trials that prove that lutetium PSMA is better than the standard of care. But we have by now quite a bit of meta-analyses, retrospective analyses from Germany and from Australia, who actually all point into the same direction, that we actually are able to improve progression-free survival and overall survival for patients when we use PSMA with lutetium. That was leading to this slide, 2017, at the American Conference of Nuclear Medicine. And of course, if you talk about 2.5 billions, then everybody was waking up, and that's how the session was crowded after this slide, when you try to get and see something about gallium and lutetium PSMA. And even if we don't go into the therapy part, it becomes obvious that once we are really able to treat patients with lutetium PSMA, the demand for gallium PSMA will become huge. Now, is gallium really such a good nuclide for imaging? As I said, it has advantages and it has disadvantages. One advantage is with F18 together or with scandium, it has quite a high beta positron fraction, so you get a good yield of what you actually need to do the imaging. Copper and zirconium are not really ideal for this purpose. Then the half-life, it's a bit short. So logistics becomes more complicated if you compare this with F18, scandium, or copper. That's maybe orange. It's not impossible, it's just a challenge. Then we have other challenges. Scandium, for example, has quite a high gamma fraction. Of course, the energy is really a challenge. Here, scandium and copper are a little bit less energetic. Gallium has really quite a high energy. And what this means for imaging, I will show you later on, because of course you have more scatter, you have more noise, and you need to be able to correct for this. The good thing is you can use it with a chelator. So for the teragnostic approach, we all know F18, it's not ideal because you always need to have a different chemistry for the diagnostical component compared to then the therapeutic nuclide. So how is it produced? Generator, cyclotron. I think gallium can be done in both. So this is neutral. So now let's see, what do I mean with the scatter? If you compare the energy of a fluoride compared to a gallium, you see that especially in lung tissue, the travel distance you have until you have the annihilation is much higher. So the resolution of your image with gallium is never going to be as good as if you could use an F18. This is also shown in many phantom studies and very hard to overcome. Is this really making a huge difference? I was used to those images and I thought the image quality is actually good. So this is a case of a patient with a grade 1 neuroendocrine tumor of the terminal ileum. He was incomplete resected, so they did not take out the nodes, and he actually refused to have an additional surgery. Then the surgeon said, okay, let's do a PET, and if the PET doesn't show distant disease, you should really go and remove the nodes. The patient got the scan, and I did not see any additional distant disease and recommended a lymph node resection. The patient refused and said, no, I'm coming a year later for another scan. The technologists made a mistake, and he just came back, you see here, 3 months later. Oops. And what's the difference? It's just a new scanner. So with the new digital detectors, we definitely overcame some of the limitations, and especially the scatters. And suddenly you see something, sorry, that was too fast, that was present in the previous exam, just too small to be detected. And yes, in most of the patients, I think those upgrades, those new scanners don't really do a lot, but in some patients, they just make the whole difference. So what was behind this scanner change? We went from the usual analog detectors to the digital TOF detectors, and I think the most important benefit was really that you had a slightly larger field of view, but overall definitely an increase in sensitivity, and this, of course, helps a lot. So that was 2017. What comes 2018? We just added another ring system to it. Again, an increase in sensitivity. And again, you can ask yourself, okay, if you now have those super sensitive crystals, do you really need to have 5 rings? Isn't 4 ring enough? I mean, the installation was done quite quick. We started on a Monday, and the first patient was actually scanned on the first day. That's quite impressive. And with the 4-ring system, I already thought that the image quality is absolutely fabulous. You see here a patient that actually was scanned on the 5-ring system and the 4-ring system. And yes, again, you see an increase in lesion detection on the 5-ring system because there's a higher sensitivity. You could say, okay, that is, of course, a time delay between both scans, so maybe it's just a progression in disease. But the meningioma of the patient definitely didn't change. And you can see how the conspicuity of the lesion just improved, of course, due to the higher sensitivity of the 5-ring system. Now, image reconstruction also improved a lot in the last few years. And QClear is really something that is great in being able to recover the total activity of a lesion without increasing the noise in the image. This is an FDG PET scan with 155 megabecquerel, and you see how you really, with an increase in the B values, you reduce the noise in the image. Be careful if you apply this to your gallium, because with the same B values that are considered optimal for FDG, you have very noisy PSMA images. So if you have gallium, you always need to increase your B values if you want to use QClear to optimize your image quality. Now, this is all about the reconstruction, and the patient I showed you before here, or no, that's another case where we actually did the 5-ring system not only with QClear, but also with DDG. DDG is now the next step to improve the image quality, especially for the base of the lung and the liver, because it calculates the sinogram into different time steps and looks at the position of the major activity, so that actually automatically the computer can realize whether the patient took a deep breath or not. This activity then is transferred back into the average position, and that improves, of course, the conspicuity of a lesion in the liver considerably. This is an image, again, gallium. You see maybe here a lesion. Faintly, this could be 1, 2, But once you correct for the respiratory motion, I mean, it's also easy to see how you really, sorry, that was too fast, how you reduce the blurriness of the lesion, how they are not like, they become real dots and not ovals anymore. This here also a case, of course that's not gallium, you see it also works for FDG, where you see in the liver a lot of those lesions, not real dots, but like smeared, and how they really become much more conspicuous, you can delineate them better. And of course, there are some small lesions that were not visible without this respiration correction that suddenly become apparent when you do this correction. It takes a little bit more time, but I think it's well invested if you have the possibility to really also go for those small lesions in the base of the lung and the liver. Now, solutions on PEDMR. PEDMR is tricky because in PEDMR, you have the same issues with scatter, and especially if you then go for gallium, this really becomes an issue because you have a high concentration of gallium PSMA in the urine and much higher lesion to background activity differences compared to FDG. And that's leading to images like this, where you have huge signal voids between the kidneys and around the bladder. And especially for gallium PSMA, the prostate. So you really get into troubles to reach such high activities in the kidneys and the bladder. And then you need to have proper scatter correction on the PEDMR system as well to really improve the image quality a lot. And these are now cases of patients where you have very high activity in the bladders, and you see that these halo artifacts around the bladders are completely taken care of by the new program or by the new scatter correction that's available for PET-MRI for gallium. So now the challenge. I would say the high energy, at least with the PET-MR that has the proper scatter correction and the digital PET-CT, solved. I mean, we really can get very nice and high resolution image qualities also with gallium. The half-life, yeah, it's still kind of an issue. It just limits the distribution radius. Now, the advantage of this generator thing is that if you have a generator on site, you are autonomous, you can produce your own gallium. The problem with this is you have small yields. So with one generator, you are able to maybe do 2 patients per batch. And we all know that this, of course, relates to high costs per patient, because it's not the costs per patient dose, it's the cost per batch that is more or less the limiting factor. Now, if gallium really becomes a workhorse for nuclear medicine, this becomes a problem, and we'll have to think about new solutions. So one idea is, of course, cyclotron production. Again, a liquid target exists already for quite a while, but the yield was not really good enough to then really improve the applications of gallium in a wider spectrum. So GE started to develop the solid target. Actually, the first unit was installed in Zurich, and we now have the first productions and also stable radiochemistry then for gallium PSMA, and will be able to really produce gallium PSMA in the cyclotron in a larger amount, similar to the F-18. That will reduce the costs and therefore, of course, also increase the availability for our patients. So everything solved about PSMA and gallium? Well, that's actually a lutetium scan. And that's what I said you before. It was an old scan I showed you. So SPECT improved just as PET did. And we are now able to not only get a very nice delineation of the lutetium SPECT, but also to do quantification. And I especially love this because I don't need the gallium scans anymore to assess response. I really can use the quantitative SPECT data to see whether a patient actually is reducing in his activity after he got lutetium treatment in the follow-up exams. So, perspective for gallium. If you are a small institution, I think a generator is a very good idea so that you are independent from the delivery of F-18s You can do a lot with gallium. It is not just PSMA, there is more to come. If you are a bigger institution, then probably the generator really can get to its limits, and you will have to select. You might use F18 PSMA if you have delivery of F18 tracers anyway, but probably the gallium is still the best nuclide to really do teragnostics. Now, if you are a very big institution happening to have a cyclotron, then probably the solid target is an interesting option to really be able to produce PSMA on a larger yield to cover the increasing demand, and to use gallium PSMA not only for then the teragnostics but also for diagnostics. Having said that, the new F18 PSMA 1007 is of course very interesting because it does not excrete so much over the kidneys, so you have less activity in the bladder and better delineation of the prostate bed. And with this, I'd like to thank my team for the help to do all that, and of course, especially the technologists, because if you work with PET-MR, it's all about good technologists. It is really something you have to keep in mind if you want to start with PET-MR units, and I'd like to thank you for your attention.
Thank you very much for your excellent and comprehensive presentation. And any questions from audience, please? Вопрос, пожалуйста, задали. Please.
Thank you very much for the presentation. Is this solid target for gallium-68 is generally available?
I think this question we'll have to ask GE. We are still, as far as I know, in the developing phase, but I think as now the product seems to be stable, and they also could solve some of the issues with contamination with other galliums. 67, for example, was a little bit of a topic, but this seems to be solved. So I think the gentleman to your back has the answer.
Да, уважаемые дамы и господа, был вот вопрос, насколько доступна уже твердотельная галлиевая мишень для нашего циклотрона. Вот как сказала многоуважаемая Ирен A.Burger, тот прототип, который появился у них в Цюрихском университете, первый, показывает очень хорошие результаты, и, скажем так, коммерчески доступный продукт, который встанет на любой циклотрон трей существующий, будет готов в ближайшее время. Я думаю, что традиционно компания представляет свои новинки ближе к концу года, а интересы типа Iren. Я думаю, что там она будет представлена как готовый продукт.
Еще вопросы, пожалуйста. У меня есть вопрос. Я задам его. I'll ask in Russian, then I'll translate in English. Okay. Мы хорошо знаем, что ПСМА в основном используется для диагностики опухолей предстательной железы и главной метастазов предстательной железы. Рак предстательной железы. У меня вот вопрос, можем ли мы использовать этот биомаркер собственной ангиогенеза для выявления опухолевых локализаций? Есть ли такой опыт?
Honestly, I would love to use PSMA in so many other cases. So far, I have thyroid cancer. One patient we did, she was refractory to iodine. Nothing worked anymore. The TG was just rising. So we did a PSMA scan. It was super PSMA avid, and she even got lutetium PSMA in Heidelberg. And that was the first treatment since a while that actually caused the TG to decrease. Renal cell cancer would be great. Some people, hepatocellular would be fantastic. There are so many diseases. Also for hepatocellular, I already started to work on a protocol for a prospective trial. Unfortunately, this all then always is really tricky. You need to get the histology, and there's nothing that is really done in routine yet. But I think it's a question of time. And I'm quite sure that PSMA will be used also for the primary prostate, and B, also for other tumors.
Я переведу тогда ответ.
С удовольствием. Ирен была бы очень рада сказать, что да, действительно, PSMA мы можем использовать, потому что с ее точки зрения это действительно очень перспективный радиофармпрепарат, и несколько уже случаев, которые они могли оценить у себя, и первое это была рефрактерность к йоду, и использовали в результате PSMA для лечения, и получили впервые у этой пациентки действительно положительные результаты, и мы можем говорить и о раке почки светлоклеточном, и о гепатоцеллюлярной карциноме, и о других локализациях, поэтому на сегодняшний день мы не имеем ничего в рутинной практике, но очень надеемся, что вот эти вот начинающие исследования в будущем приведут к тому, что PSMA будет использоваться как трейсер и для диагностики раков других локализаций.
Спасибо. Пожалуйста.
Very short question. Because we have a big experience, as I can understand, with PSMA, my question would be how specific is accumulation of gallium PSMA in mediastinal lymph nodes in patients with prostate cancer? Because sometimes when we see many foci and with involvement of abdominal lymph nodes or pelvic lymph nodes, we are thinking that it is logical and it is the development of the process. But when we see only accumulation in mediastinal lymph nodes, for us it is a question, what is it?
Granulomatous disease. Granulomatous disease is positive on anything, on gallium dotatate, gallium PSMA, FDG. Yeah, it's exactly as you say. If it's going up and you have retroperitoneal and then you have mediastinal, you have to consider metastasis. If you have this typical mediastinum Heiler pattern and you have mild PSMA activity, I would say up to 4-ish, 5, then you have to consider granulomatous disease. If I'm really unsure and I have like one quite focal uptake, then we go for transbronchial fine needle biopsies because it's changing the whole approach for the patient. Same for supraclavicular. I love to have the needle to really confirm. In the supraclavicular nodes, so far, if it's really above 3, that's a little bit like the magic threshold for nodes, although I don't like thresholds too much. But above 3, usually it is cancer. But you can have them anywhere. And I had one case with a granulomatous lymph node obturatory to the left, just next to the tumor. I would have put my hand on fire that this is a lymph node metastasis. It was negative. One case in 180 patients we just analyzed now that got a PSMA for staging, and it is quite specific, but not 100%.
Сергей Ильич, вопрос насчет специфичности накопления ПСМА в лимфатических узлах, внутрикровных лимфатических узлах, насколько радиотрейсер специфичен. И Ирина ответила о том, что в принципе надо... Во-первых, это не очень специфичный препарат, он может накапливаться при гранулематозных заболеваниях, таких как саркоидоз. Поэтому надо в первую очередь обращать внимание на то, каким образом идет поражение в лимфатических узлах. Если это восходящий характер поражения, сначала мы видим лимфатические узлы в заблюшенном пространстве, и потом они, оказывается, потом мы их видим накопление средостений, и вероятнее всего это все-таки метастатический процесс. Если же мы видим иной характер поражения лимфатических узлов, сверху вниз, так называемые паратрахеальные и поражение трахеобронхиальных бронхопульмональных лимфоузлов, то есть типичное для гранулематозного поражения. Всегда очень сложна диагностика одиночных лимфатических узлов, накапливающих радиофармпрепараты. В этой ситуации нужна контригольная биопсия. Она рассказала о технических случаях, которые были в ее практике, в частности, о том, когда видела лимфатические узлы в подключичной области, потребовалась биопсия. В то же время надо говорить, что бывает гранулематозное поражение лимфатических узлов в тазовом для того, чтобы определить этот процесс. Ну и в принципе бывают случаи, когда в основании накапливаются метастазы. Я поделилась своим опытом.
Maybe just one more caveat, ganglias and schwannomas. So neurons also have high PSMA expression. This caused in the beginning, especially the celiac and the stellate ganglia caused issues. Stellate ganglia is not easy to distinguish from a supraclavicular node. So these are the two things you always have to keep in mind. It can be granulomatose, and if it looks like a neural structure, then really rethink. And then I usually do dedicated MRs if I'm not sure.
Также Ирен сказала, что препарат может накапливаться в ганглиях, это ганглии черные и ганглии звездчатые, и очень сложная диагностика между метастазом в четырех полосах звездчатых ганглием, и здесь другие технологии могут нам помочь в этой диагностике. Кроме того, радиопрепарат может накапливаться